I'm going to present in English, and I will try to speak up so you can hear. So, okay, I have only federal government support in my grants. We use this in the United States to say it in every presentation. So, I'm going to talk about today how we determine the evidence in epidemiological and genetic studies. So I apologize that it will have clinical implications, but I will actually talk to you about things that I hope some of you may not know. So the first question is a question of severity and the question of specifiers in the diagnosis of autism spectrum disorder, official diagnosis. The challenges in phenotyping in epidemiological studies and genetic studies, and challenges that these bring forth in treatment. So the idea of autism as a spectrum has been supported by a number of genetic studies, of which one of the most fundamental one was the one that was completed by Anne Le Couture with Michael Rutter, and showing that there was an overrepresentation of the phenotype in monozygotic twins versus dizygotic twins. And the idea was also incorporated, although it was never incorporated as a spectrum, under what we used to call in the Diagnostic and Statistical Manual, the third edition, 1980, the first one, as an umbrella category, which was called pervasive developmental disorders. And this was subsequently in 1987 in DSM-3R and subsequent versions was also, there was a subcategory of the pervasive developmental disorder called the pervasive developmental disorder not otherwise specified. I was actually at a presentation in Istanbul, and there was a Turkish name for this which I couldn't pronounce, so I gave up. So some of you may know this. So there are a lot of changes in the diagnosis of what we now call as autism spectrum disorder that went from the original conceptualization in 1980 in DSM-3 as childhood autism or autistic disorder subsequently, and otherwise also known as Kanner autism or infantile autism, to what we today call autism spectrum disorder, was a combination of number of other categories that have been incorporated into this. And I will get back to some of those categories as well. So Lorna Wing was the first person to use the term autism spectrum disorder in the 1970s. She's also the founder of the Autistic Society and was a parent of a son with autism. The publication of the ICD-10 was a very critical moment in the history of autism diagnosis, because it for the first time introduced the diagnosis of Asperger disorder. No one had heard about in 1992 Asperger disorder. I was in the United States, and I can give you vignettes, but I don't have time. And then this was subsequently was so successful, it was incorporated in the DSM-4. And the third step is the publication of the DSM-5, which incorporated this whole thing and essentially eliminated Asperger disorder and combined all into this DSM-3 diagnosis of what we call autism spectrum disorder. So this is actually a crosswalk to show you that there are these three domains on the left-hand side, which were the DSM-4R, the autism spectrum disorder, which then many of these items were then transferred on the left-hand side of the column, the DSM-5, under two domains, the top three and the bottom four. And essentially what you see is that the same criteria were kept, with the exception of one very important criteria, which is the delay in total lack of development of a spoken language, which became a specifier, which in fact was the criterion that was absent in the definition of Asperger disorder, which essentially to argue that the autism spectrum disorder is a generalization of the definition of Asperger disorder, and because it doesn't also have any implications of any kind of a delay in language as a requirement, and there's also no delay in intellectual development, which also essentially includes high-functioning autism. So it's a combination of high-functioning autism and what we used to call autistic disorder. So it's a generalization. So there's really not a major change, except these criteria were combined, which is very confusing. But also what you see is that the criteria was actually bolstered by more words that make it more complex. The most important second change was the introduction of this hyperreactivity with the sensory issues in the ASD, which is a very important criterion that was added. So, in terms of the severity, if those of you who studied the diagnostic manual, the DSM-5, you will see that there is actually a severity criteria mentioned for autism, but which no one actually uses. What you will see, and I will point out this issue, is that on the social communication and social interaction domain, there are all the items have to be endorsed. So there are 3 items out of 3 have to be endorsed. And so the levels of the severity is a combination of the items and a qualitative increase in the severity, which is different than the repetitive behavior, where there's only 2 out of 4 items have to be endorsed, and as you add more items, you get more severity. So you can see that there is a real inconsistency there in the psychometrics, because one includes all the items, the other one has additive items, and it doesn't look at the qualitative changes of the items, which the first domain does. So there's those of you who know statistics and psychometrics, that's a huge problem when you're doing factor analysis. Okay, so then you have these levels of support that are required, which are the indication, which is very subjective, of what the levels of support will be. Now, you could have a child who might have a different severity on restricted impairments of repetitive behavior and might have perhaps much more social communication difficulties. So how do you combine the first column and the second column and the different factors into one severity global score? We actually did this in a cost effectiveness analysis, economics of autism study, and we tried to conceptualize this into one severity score, because it's very difficult from a research point of view to come with a severity score. Now, the ICD-11, those of you who are waiting to use, I know in Turkey you use the DSM-5, but the ICD-11 actually is going to be very helpful, because it's indicating these different codings that includes mild or no impairment of functional language, absence of functional language. Actually, it has a segment with loss of previously acquired skills, which is some subtype of autistic children have, and also the other and unspecified, which is really like the pervasive developmental disorder or the atypical autism. So the DSM ICD-11 is an important addition to the specifier and the severity of the DSM-5. And what it doesn't do, which we need to do, is that in the intellectual developmental disorder, it doesn't tell us what mild, moderate, and severe. But that's actually separate for if you have an intellectual disability, you need to decide whether it's unspecified, mild, moderate, or severe, or profound. So these are the 2 recent definitions of ASD for research purposes. So in terms of the area that I've actually talked about this in Prague, so I didn't want to repeat my lecture in Prague here because some of you have been there, but there is this what I call BIF, or the borderline intellectual functioning group, which actually has no intellectual disability, but it's a very significant 13% of the population, and this group is overrepresented in the autism spectrum group. As those of you who work with autism patients, you know that they don't have intellectual disability, but yes, they have adaptive functioning deficits, and they actually have borderline intellectual functioning, which we don't pay attention, but also because they don't qualify for services. And it might be also for Turkey, because I'm not sure, but in the United States now, we can qualify for services if you have just autism diagnosis. But in the past, you had to have intellectual disability to get better services. Okay? So, question of variation. I show something about Charles Darwin on all my presentations. So this is actually the walk behind Charles Darwin's home. And he used to walk every day on this and to talk about how the human variation occurred in writing his books. So it is not the strongest species that survive, but neither is the most intelligent, but it's the one that's most adaptable. to the environment. So the genetic risk factors are conceptualized under two categories, the common variants and the rare variants. So the rare variants is pretty simple. These are those of you who are in developmental medicine and neurogenetics, you know all these disorders. The top three actually are the most important. The Rett's disorder, which used to be associated with autism, is no longer. And then, of course, Fragile X syndrome and tuberous sclerosis. Tuberous sclerosis is very significantly associated with autism, something in 25 to 40%. So these are single gene disorders, and they're very rare. And we know them because they have specific genetics. So going back to the rare variants are very important because they contributed small phenotypic effects, and they're very difficult to detect, and you can only detect them in very large-scale genetic studies. So, most genetic risk for autism resides with the common variation. This is a paper from Nature Genetics. So we did a study with Dr. Robinson at the School of Public Health at the time. So to look at the stability, this is the Avon longitudinal study in England from these parents, and then we've only sampled 6,000 of them, and using a social communication study that looks at autistic traits in this questionnaire. And we found that the autism trait scores were very stable, but the top 95 percentile, was the top two lines, were also very stable, so that there was a very important, across ages 7, 10 and 13, there was a stability of autistic traits in the population. So suggestive that there is some kind of genetic stuff that's going on in the population, and this might be relevant to the common variants effect. So another important finding was the female protective effect, and those of you might not know this, but there is a male-female ratio, as you know, and it's 4:1, and this ratio is actually higher on the higher IQ ranges. The male-female ratio, as the high IQ goes up, is much higher, so there are more males than females, and as you go down the IQ scale, the ratio changes. There is maybe 2:1 or even 1:1 score, so that it becomes evened out. The other important issue that we didn't know until the studies found out recently, that there is need for greater familial loading in the siblings and families of those patients who are female patients with autism. So they require more genetic loading to express autism. So that's a very important finding. So there is no supportive evidence at this time that there is some kind of an X-linked common genetic locus that will mediate this. We don't know this. Some other people have looked at this, but they have not found the evidence yet. But this is a very important route to discover therapeutic targets, in fact, to understand why female are more protected. So this is the graph that shows you the loading, that the blue bars for the female probands having with siblings and also other family members with autism. So this is not some people have said this might be because of case ascertainment, that we don't ascertain female cases with autism very well, but that's not explained by that. But there's also some ascertainment issues related to females, and there are significant ascertainment issues related to, I will show you, with states across the United States, race, ethnicity, as well. So this is a very important graph. It's probably one of the most important graphs for those in the United States that would look at it, but they actually don't really care that much. This issue is that when you see the black population, the African American population, have a much higher level of intellectual disability. They're more diagnosed with intellectual disability when they present with autism. And also that might be, we did a study in Nigeria that showed also that those who came for services had higher levels of intellectual disability. That's basically an ascertainment bias that also says that we're not detecting the milder cases of African American patients in the United States. When you look at the ratios, you'll see that, again, the higher functioning without intellectual disability has a more male to female ratio there. These are the CDC data, again from the Center for Disease Control of the United States, that shows significant disparities across the states. The top one on the right is New Jersey. That actually was the first study. I don't know if those of you who read autism epidemiology was the BRIC counter study that showed that there was a very high rate of autism in the US population that took so much attention across all the media. But when you look at Alabama, you'll see how the disparities are in terms of the rates of autism. So we have rates of autism differences by gender, rates of autism differences by geographical location, and rates of autism differences by race and ethnicity. And I'm sure this is true also in Turkey if you did rural studies versus studies in cities and all sorts of socioeconomic. So this is actually graphs to show you how that is changing. The rates of autism and recognition of autism is increasing. It's also increasing in Turkey, where people are becoming more aware, and the rates are also increasing. So this is a very important study conducted in Sweden that showed you in the quantiles that actually there is a socioeconomic risk for autism. We used to think that autism is a high socioeconomic disease. Like people used to think that bipolar disorder was like that too. But when they did a study in Sweden, this is a very important large-scale study, you find out that actually the quantile phi, which is the highest socioeconomic position, is the reference value, and the odds ratios go up as you go. And that's true both for the autism with intellectual disability and autism without intellectual disability. So the autism traits are a tabula rasa, especially with the autism spectrum disorder. So the genome-wide association studies that people are conducting at the moment, and there's a recent meta-analysis that just came out in Nature Genetics in 2019 that shows that nearly all persons in Denmark, actually, this was a very large-scale study of 18,000 ASD cases, there was both quantitative and qualitative evidence for heterogeneity of autism, and these were autistic patients diagnosed according to DSM-4. Okay, so the common genetic variants contribute to ASD susceptibility, but there was no individual robustly associated ASD subtype. However, there were some indications, again, based on what I told you, of strong differences in the heritability of ASD subtypes with and without intellectual disability. So this is what we actually threw out in terms of the definition, but it's the most important element that predicts heritability, intellectual disability. And it's not unique to intellectual disability, it's unique to autism. So IQ correlates positively with family history of psychiatric disorders. What does that mean? As the IQ goes up, history of psychiatric disorders goes up. So hence there is more work for psychiatrists working for high-functioning people with autism, right? And contribution of common variants are also more common in high-functioning ASD cases. So this is again a study that Elise Robinson did and was published in the Proceedings of the National Academy of Sciences that looks at the de novo mutations. This is again looking at these genomic studies that shows that the de novo mutation rate goes up as the IQ scores falls in the cohort of cases with ASD in the population. So, and this is actually the family history of psychiatric disorder and family history specific bipolar disorder and schizophrenia, and that goes up with the IQ scores, which I was telling you about. So, conclusion, and I'm going to try to stop on time. So what do we know in terms of conclusions? So epidemiological and genetic research contributes to our understanding of insights into the autism, and it's very important in the future. So there is a need to improve phenotyping strategies of ASD subtypes. So the DSM-5 ASD is not going to help us very much. We need to be much more careful in phenotyping autism. We need to reduce the inconsistency in the use of dimensional and discrete measures of autism. And we need to validate our scales, and in the scales also in the language of the country, and adapt it to the culture of the country. The ICD-11 is going to be an important improvement, in my view, in introducing this very specific coding parameters that's going to be very helpful to clinicians and researchers. Genetic and genomic research is going to be providing robust insights in our understanding, especially of the common variant association in ASD subtypes, which is very subtle. It's like a puzzle, and we are learning more and more with these very large-scale studies, because the variants are very common in typical people as well as the people with autism, and therefore we need very large-scale studies to make these determinations. Future research is likely to further continue to our understanding of interrelationships between autism spectrum disorder and other neuropsychiatric and neurodevelopmental conditions. This includes schizophrenia. It also includes many other neurodevelopmental conditions as well. Understanding of the etiologies and mechanisms will help us in developing better targeted strategies. Besides very important considerations that Dr. Munir mentioned in terms of early intervention, functional behavioral analysis, and all sorts of other types of interventions that people are evaluating through very important evidence-based approaches. Finally, there is a need to overlook we need not to overlook important disparities across gender, race, resource-poor geographical areas, parental socioeconomic position, as well as vulnerable and stigmatized populations. These are the populations that suffer the most from autism. They bear the greatest burden of autism, and they need our help the most. And so I'm very committed, as someone interested in epidemiology and public health, to say that that's a very important group that we need to help and identify. And on that note, I end, and I give tribute to my teacher, Sir Jonathan Miller. He's 87 years old, and he became an artist in his late age, looking at this work of modern art. Actually, I'm fascinated by the